think we are ready.
We are ready now.
Right. Good evening, doctors. Thank you for being with us today. Today we introduce to you a new paradigm in anterior segment imaging, the Anterion. On behalf of the management of Toshbro Medicals, I welcome you and we look forward to your participation. The ground rules, of course, being that there is a section of question and answers. You can type in your questions and we will be happy to answer them. Our panelists will be happy to answer them. When we talk about Anterion, we are talking of a single platform for imaging, measuring all the parameters that you need for anterior segment analysis, monitoring, and evaluation. We have with us a very elite panel of users who are using the Anterion in India and abroad. And without much ado, I introduce you to the panelists. The webinar today is being anchored by Professor Rohit Shetty. Professor Shetty needs no introduction. His academic and professional successes are religion, and I trying to talk about them would be like a firefly trying to talk about the moon's light. But what draws most people to him is his understanding and support of the young, the new breed of ophthalmic surgeons, as well as anybody who needs guidance in this field, whether it's somebody from the trade or somebody from the fraternity. He full-heartedly supports them, encourages them. Thank you, Dr. Shetty, for being with us today. We're very proud to have you and your team with us. So without much ado, I hand over the webinar and the steering of the same to you. Thank you, Dr. Shetty.
Thank you, Shanaz, for those kind words. It's one of those webinars, very few webinars I've been part of where we are speaking about one technology for the whole hour. At the onset, I would like to say that I have been a researcher for Heidelberg, published many papers on confocal, but I don't have any financial interest, unfortunately. And they're very good friends out here. I mean, Martin, I go a long way, you know, maybe 15, 16 years back. And he's been the face of Heidelberg for all of us from India, because very approachable and very happy to see you. And also very happy to see Adam, also very good technical support. I have a fantastic young team. Anterion is also a very young technology. So you will not have gray hairs and white beards, people sitting for 10, 15 years to understand that, like your spectralis or confocal microscopy. So we decided to keep a young team because it's the youngest baby in your family, I guess. Right, Martin?
Absolutely, absolutely.
So we thought we'll bring in the young crowd to understand the young one, because there should not be cultural differences of you know, the age out here. I had seen this technology maybe 2-3 years back at ESCRS booth. I'm not sure whether it was Copenhagen or before that. I think it was Copenhagen. So the good old days of travel. And so I was thoroughly impressed the way the OCT was. It was not, it did not have a name. It did not have a, I did not really know where it belonged to. I think they were just testing out on people to see what they were opinion about. And at that point of time, I told Shanaz that whenever it comes to market, we should be the first. Not that I was interested in being the first or second, it's just that I was keen on using this technology because I just enjoyed it. And Shanaz made sure that it came to us. And I think we probably have the longest experience of using this technology in the country and maybe in the world. And I have a fantastic young team of Rohan. He's done a lot of work on the Anterion. He did present his data in All India Ophthalmic Society meeting, and it was very well received. In fact, we had submitted a few papers to the ASCRS also, and many other conferences. Unfortunately, it did not happen. And his area of work is Iol calculation. I think we have some data now. We are writing it as a paper. Should come out with some publication shortly. We have Dr. Nikhil. Again, his interest is imaging, and he's going to speak about different ways in which Anterion can be used for just not for the cataract surgeon, for any other specialties also. Dr. Namrata, she will speak on how Anterion gets, how when you compare Anterion with your topography. Now, topography becomes very important integral part of your cataract workup. Earlier, topography was only in the refractive domain. Now, cataract surgeons, I consider it's a sin if you don't do a topography and get a cataract surgery done. It is so important. It's like many years back, you're doing a LASIK surgery without a topography. I think if you're not doing it, please adopt it. Even if you don't want to buy an Anterion now, buy a topographer and please use it. At some point of time, you'll realize that one machine which can do everything would always score over the rest. I have Dr. Pooja Khamar. She's a consultant in cornea cataract refractive surgery. She's done a PhD on different refractive platforms. Her areas of interest in today's talk is about how she's using it in ICL, phakic lenses, basically. And so all of us today are going to speak on multi-purpose use of Anterion, okay, with no financial interest. I'm saying it with a lot of, I'm putting a lot of stress on this word, multi-purposes. Post-COVID, the new normal is how you can make one machine do multiple things. The luxury of having 5 machines to do one thing phases over to a large extent. So, because it has to be quick. For example, you use a topography, you have to make a patient get up, go to a new place. If you use a IOL master or a lens star, you have to make the patient again move on. So what happens is, in today's world, more the movement of the patient, the more the chance of all kinds of stress of the spread. So if you are bringing a machine which gives you everything in one go, I think that's a new normal. I think what I feel is now I've started making very clear that I want one machine which does everything for me, so that becomes a new normal. So I'm not going to waste more time, but I'm sure my message is very clear. Whether it's Anterion or any other thing, bring in technologies which can do multi-purpose. It saves money, and it's most important. It comes into the philosophy of post-COVID life, where you're working on segregation and distancing. So I would. This is my talk. I did not use any slides. And I would like to invite Dr. Rohan to speak on cataract, IOL, and how it's a multi-purpose tool for him as a young cataract surgeon using a young technology. Rohan, all yours.
A very good evening to everybody. I would like to thank Professor Dr. Rohit Shetty for giving me this opportunity to speak on this platform with such bright minds listening and such bright minds also giving talks here. So the topic for my presentation is the new hybrid OCT station for cataract, a way forward. So the Anterion, as Sir has mentioned, is a multimodal imaging platform optimized for the anterior segment. High quality images and comprehensive measurement is the norm. It minimizes the time needed to perform multiple anterior segment examinations That means there's no need to move the patient. And in post-COVID era, as Sir said, this is going to be, a great thing in the armamentarium for machines like Anterion. It has a short acquisition time and also has the eye tracking technology. So what are the advantages that the Anterion gives us? It has high resolution OCT image of the whole anterior segment, including the anterior chamber angle, which is important for cataract surgical planning. The corneal maps curvature and elevation of the anterior and posterior surfaces of the cornea, which is important for toric IOL's pre-evaluation, and toric IOL calculation is also included in the software. The corneal wavefront analysis, which is important for multifocal IOL's pre-evaluation, and the possibility to change the segmentation manually, the posterior corneal surface, anterior and posterior lens surface, and axial length. It also has the metrics and imaging app, which will be covered subsequently. So this is a table, first of all, showing the differentiation of the Anterion as compared to the other machines available in the market, and how Anterion has these 4 apps: the Cornea, Cataract, the metrics, and the imaging app. Whereas all the other machines would have either 1 or 2 of them, but not combining all the technologies together. So it's an all-in-one machine, which gives us the benefits in the imaging for the cornea, the anterior chamber, and visualization of the anterior and posterior lens surfaces. In the Cornea app for the corneal topography, the corneal tomography, total corneal astigmatism, the corneal power, and the pachymetry. In the metrics app for the anterior chamber analysis and the anterior chamber angle assessment, and the cataract app for the corneal topography, cornea analysis, anterior chamber analysis, and the lens thickness, along with the IOL calculation, which is integrated in the system. The principal is swept source OCT with a wavelength of 1300 nanometers. It has a digital axial resolution of less than 10 micron and a scan depth of 14 millimeters. So how the interface for the cataract surgeon works is that it combines basic measurements for planning, that is the corneal analysis, the anterior chamber depth, lens thickness, and axial length. So the OCT section images to visualize the entire anterior chamber and the representation of the retinal profile even through the dense cataracts. That's another great advantage that the Anterion gives you. And we've tested it over and over again. Through opacities and dense cataracts, it easily goes through and gives us the accurate axial length. In fact, the range for the axial length, it goes up to 3 decimal points. As we can see here, it's giving us an axial length of 22.86 millimeters with a plus minus of a 0.001. So that's how accurate it is. And once we click onto the axial length, we can also get a pictorial representation of it. So it provides all measurements for the spheric and the toric IOL calculations, including the Iol Calculator. The Iol calculation is done with ray tracing, that is the Oculix software, and the consideration of lens thickness and posterior surface of the cornea is taken into account. I'll be discussing this in subsequent slides. So this is how the interface page of the Cornea app is once the scan has been taken. So what are the points that are there here? In the middle, we have the OCT image. Then we have the intensity profile. Below that is the axial length measurement. And we have the display options right at the bottom of the screen. On this, the main thing here is on the same page, it also gives you the Cornea map. Once you click on that Cornea map, you'll be able to straight away go to the topography of it. You can also change the status of the eye by clicking the axial window over here. Once you click this, it gives you all the options of the eye status. You can change that from phakic to phakic IOL, aphakic, pseudophakic, or piggyback IOL in a single click. Now, the axial length, as I said, you do a double click and it gives you a pictorial representation of the axial length. You can also enter the axial length manually in cases of dense cataracts, but as we have seen in our experience very pleasantly, we've not been using this feature even once. So as dense as the cataract is, it has given us for each and every density of the cataract, the axial length computed on the machine only. We have not had to go and take the patient onto a contact or an immersion biometer, take the axial length over there and enter it manually. But still the option is here. Although in our experience of over 250 eyes that we have done, we have not been using this feature even once. Again, you can edit segmentations. So that is to say, there is segmentation that is already given on the machine. The machine already gives us a segmentation of what it feels is the surface of the cornea, of the iris and the lens. But we can always change that by clicking this, and we can use a drag and drop option, and you can move the segmentation line to where you feel it is correct. Now, this is the Iol Calculator part of it. And now here we can see that we can enter the target refraction, whatever is the target refraction we want in case we are doing a monovision for the second eye. Then we can select a desired formula and an IOL. So we can see you have the Holiday, the SRKT, mentioned here, you have the Haggis, the Haggis L, and recently incorporated the Barrett's Universal 2 formula is also there in the software. So that gives you a variety of formulas to choose from. Post which you can select the IOL power based on the IOL. It also has a list of various IOLs that are there, which you can choose if you depending on your practice, whatever are the IOLs that you are using. Going on to the toric part of it, the toric, you can enter incision, you can enter the induced astigmatism. The incision can be set manually as well. So this is where it's extremely, I think, scores a little bit over the Barrett's that we use normally, the Barrett's toric IOL formula, wherein the incision, when we have to enter it manually, we have to keep going back to the formula and keep entering it manually, say for 5 degrees or 10 degrees of change where we want to enter the incision. Here you can just toggle with it and play around, and at the bottom you will get what the residual astigmatism is going to be real time. So it helps in selection of the toric IOL power by manually actually changing your incision site. So how that helps us in a cataract surgery is we can determine where is the sitting position that we are going to have. So normally we are doing our cases temporally, but depending upon where the astigmatism is, we can place the incision there. So along with the toric, with our incision also, we can correct the astigmatism. As I said, the Barrett Universal 2 formula has now been incorporated into the system. So long-term, if long-term how it is going to be doing, we'll get a data of that because now we are using Barrett for all our biometers, and we choose our IOL powers depending upon the Barrett formula. So to summarize, it uses the swept source OCT. It penetrates cataracts and opacities. Multiple step acquisition in one capture, a cornea curvature, AC depth and axial length. It links to the Oculix database and IOL calculator. It includes the SRKT, Holiday 1, Haggis, Haggis L, Hoffer Q, and Barrett Universal 2 formula. But this Barrett Universal is additional license is required. So it will not come with the machine. I think you have to pay a premium, which probably the company can look into, especially post-COVID, and incorporate this Barrett into the system itself. Thank you.
Superb, Rohan, as usual. Very clear, concise, and very neat presentations. I would like to ask if there are any questions on the grouping posted for him at this point of time, or you would like to take it later. Martin, before Shenaz is trying to figure out what questions are there for Rohan, would you like to add your final thoughts on this? I know there's no final thoughts, but on your insights onto this.
No, I think actually, to be honest,
you're mute. You're mute.
Ah, I'm mute. Sachin has to unmute me.
We can't hear you, Martin. We can't hear you.
Okay, Sachin, can you put me on?
Oh, we can hear him.
Can you hear me?
Yes.
Yes.
Nobody
Can you hear me now?
Yes, Martin, we can hear you.
Ah, okay. Thanks, Dr. Shetty. Can you hear me now?
Yeah.
Ah, okay. Okay. I think Dr. Rohan did a fantastic job to give an overview of the Anterion. I really don't have anything to add. I mean, actually, probably I was going to present maybe in a different way, but the same thing. So Dr. Rohan already said everything probably that needs to be said. It's maybe efficient because you're not moving patients between machines. And probably this is one of the biggest advantage of all.
Yeah, absolutely. I think the biggest advantage now in COVID is you're not moving the patients out.
Yeah.
I think that's the biggest USP. I think that's something bigger than anything you can think of from the optical point of view.
And this wasn't envisaged before COVID, so this was just by luck.
Adam, do you want to add anything?
No, I think it's completely, as everyone was saying, you know, the time efficiency is the big advantage with the Anterion, as well as not having to use the manual biometers as much, go back to acoustic or immersion biometry. All of that adds up to a better patient experience and a better throughput through the clinic. If you take into account it's about 5 to 10 minutes to move a patient between machines, there's half an hour per patient that you've saved.
And billions of aerosols you prevent.
Yes.
Nikhil, you want to add anything? What is your take on from a cataract surgeon point of view? I know you're speaking later.
So from our experience, we've seen that the Anterion penetrates even the most dense cataracts. I would be demonstrating a few cases further where even a mature cataract, which was not picked up by the other high-end biometers too, was we could get the axial length measurements on the Anterion.
Fantastic. So Shenaz, no questions? Should we move on to the
There are
next
some
speaker?
questions in the question and answer list, which I think Dr. Rohan, you can answer online.
Yes. So the first
Maybe
question
you could
is,
type out
with the access
answers.
in the barracks is also possible on the Virion planning station. Yes, that's correct. But I was talking about if you don't have the Virion planning station, then in case you have to do it manually on a computer, then you have to keep going back, entering it, clicking calculate, it takes you to the next page, and then you get to know what the exact the residual power is going to be. But whereas here you can get it live, so it saves you time on that. Up to what density of nuclear sclerosis in our experience? Well, mature cataracts, easily it is penetrating. It will be demonstrated by Dr. Nikhil in a case. All mature cataracts, it has penetrated. As I said, we have not entered manual axial length, even in one case that we have done so far on the Anterion. What is the cost? I think that Shenaz ma'am can.
How's the K reading compared to
How's the K reading compared to the true K on the IOL master?
This is
Yes.
basically
This is the basic
data of around 150 guys
on this.
And soon
And
we're
soon
going
we're
to
going
be
to be
publishing
publishing
that.
that. It is very similar to the true K that is there. Along with that, even the lens star. So we are doing an analysis based on the lens star, the IOL master, and the Anterion. The data will be out. As far as these stats results show that the compared reading is very similar. Does it do aberrometry, angle alpha and kappa? Yes, that is going to be covered in the subsequent slides. It does give you angle alpha and kappa, and the approximate price again that ma'am can take.
So we have finished all the questions. I think we want to move on to the next speaker, Dr. Pooja Khamar. She is going to speak on her experience in using this tool for an ICL. Again, ICL requires your patient multiple tests, a topography for white to white and other parameters, the angle ACD, the white to white, and the lens, biometry. So again, it's a one tool which fixes everything. So Dr. Pooja Khamar, over to you.
A very good evening to all. At the outset, I would like to thank Toshbro and Shehnaz ma'am for having me here. Rohan has very nicely covered on how to use Anterion in cataract planning. Namrata was supposed to cover the one on corneal topography maps, but I'm just going to skip the queue because of a few reasons. We do a lot of ICLs in our practice, and as Dr. Rohit Shetty sir mentioned, that it needs your topography for curvatures, it needs your anterior chamber depth, so probably you go back to the OCTs and do it. It needs your sulcus to sulcus whenever there's it needs white to white, it needs sulcus to sulcus just to have and differentiate between the discrepancy whenever there's a doubt. So whenever you do this, you have to go to multiple machines. But when Anterion came in, what we realized was that Anterion was giving us all the answers in one or the other way, whatever I required for my ICL plannings. At the outset, I have no financial disclosures of whatever I'm going to speak in this topic, be it the ICLs or the Anterion itself. And also I'll be covering it like just a brief, I'm not a glaucoma surgeon, but I'll just give you a brief insight on how this tool can be used in your glaucoma practice as well. So these are just like, this is very nicely high definition OCT itself also. So it gives you all the, you can see all the anatomical structures very nicely on the Anterion. These are the 4 imaging, the apps which you get in Anterion, which Dr. Rohan has already covered. So what is the role in ICL planning? Like, you know, there is a pre-op, like it helps me both in my pre-op planning and my post-op planning as well. How does it help in my pre-op planning? I need to take 2 apps into consideration for this. One is the Cornea app and the other is the Matrix app, because Corneal app will give me the topography, the tomography, how much the astigmatism is on the cornea, the true total cornea power, the pachymetry, and the Matrix app is going to give me the information on the anterior chamber depth. If I need to go back to the STS measurements or anything also, I can go and get it from the Matrix app. So these 2 apps are important for me when it comes to ICL planning. So let's see the Corneal app. Corneal app, how does it help? This is how the map gives us. You get your curvatures, the steep and the flat keratometries, the CCTs. You also get the pupil diameter and the wide to wide. Wide to wide is important because your ICL sizing is in a way, is dependent on your wide to wides. So it gives you all the information here on the Corneal map. Then when you have like all this, the anterior chamber, you can go to the Matrix app where you can get the anterior chamber imaging. There you can, if you have any doubt, you can also see how your cornea is on as an OCT picture, the ACDs, the lens thickness, the wide to wide, and also if you need to measure anything manually. So like at this point of time, the spur to spur distance is not available, but if you need to measure it, you can do it manually, which I'll cover in the next slide. So this is just an ICL. So there are 2 types of ICL available. As I said, no financial interests available, but we have a lot of experience with the Star Surgical, the Vision ICL, and the one, the IPCL by the Care Group. So when you have all these parameters, you just go to the online calculator given by them, and you enter all these parameters here. So you need to enter the keratometry values, the flat and the steep K with the Ds, the anterior chamber depth, the corneal thickness, the wide to wide, which you got from the Corneal app. Your refraction also, you have it from your optometrist or when you have done it by yourself. So when you enter all these parameters, you get an ICL power and the size of the ICL as well as to which size and which power is recommended for your patient. So just from one Corneal and the Matrix app, you have all the parameters here and you enter it and you straight away get your ICL power. And if you have to measure your spur to spur distance, in case you have any doubts, you can do it manually from the Matrix app. You just go to the Matrix app and do it. This is the other phakic implantable lens available from the Care Group. This is all there also online calculator. Again, no financial interests here. Star Surgical ICL doesn't ask you for spur to spur distance, but when you have like the other Indian ICLs do ask you for the STS and all that. So because when you give in more parameter, they have the regression based calculator to give you an accurate size and the power of the ICL. So again, you enter all the parameters, your keratometries, the ACDs, the spur to spur distance here, the your SIA and the incision location, your refractions here, and then it gives you a your power of your implantable colamellar lens. How does it help me in my post-op evaluation? It helps me in my post-op evaluation because what you basically see in your post-op is how your ICL is placed, whether it is in place or not, whether your vault is higher or not, or it's normal or it's very low. Because whenever there's a high vault, it can lead to angle closures and other high ocular pressures and other complaints. And if it is the case, then you might have to redo your ICL surgery or explant your lens. So here, if you can also see how your angles are. If you if your vaults are higher, as it can go into angle closure, and if it is going into angle closure and it is not being controlled, then also it gives you a picture and you can take a decision on what to do. So one thing here is like you have to manually measure your vault at this point of time, which is pretty much easy because of the resolution of the machine, it gives you a very accurate measurement of what your vault of the ICL is. Again, in low vault also, you need to be very watchful about what your low vault is, because if it's very low, below 200, you might want to probably expand it, because, or you might want to give your patient a warning, because there are chances that it can lead to a cataract formation. Also, a lot of times you see that there is a difference, like, you know, your plate haptics, your haptics are turned inside, your ICL is not in place. It will also give you an idea, because there'll be an difference between the two, like, you know, it will not be even in all the meridians. So you can also go in each meridian and measure your vault of what it is in each meridian. So these are the two things. Now let me come to, I'll just cover it briefly. Applications in glaucoma, you again go to the Metrics app, and there you just choose, you know, the segmentation. When you choose the segmentation, the machine gives you all these lines, what green, yellow, and the pink line which you see. So here, what is important as a glaucoma surgeon, one thing is the scleral spur. So it gives you a line. At here, I've obviously measured it, so it is giving you accurate, but a lot of times it is not going to be accurate. So you can manually change it and take it from one spur to the other spur, and it will give you a value. For here example, here it is 11.53, and you will get a value. The next thing which it gives you is the angle closure and the information about the angles at different variation. For example, what is the angle at 500 microns from this thing, and what is at the 700 microns. And it also gives you in different meridians. So at this point of time, I would not say that, you know, it can replace gonioscopy, but it can give you an idea about how your angles are in each meridian. And it also gives you information to trabecular meshwork about how much the value is. Thank you.
I think it's a wonderful demonstration of what this can do for an ICL surgery. Being a refractive surgeon, one of the major challenges I always find is not the surgery itself in ICL, it's about the calculation. If we can get everything which can help in getting a perfect bang-on solution, I think that's what we require. And any questions for her, Shanaz? Unmute yourself.
Yes.
Martin or Adam, you have anything to add? What Dr. Pooja has mentioned?
No, I think you all cover everything very well. So nothing for us to say.
Actually, there are a few questions. There are 3 questions on the same topic. Is individual corneal layer topography possible? Is individual corneal layer Pachy available? I don't know whether somebody can answer this.
Yeah. So at this point of time, we cannot individually measure the pachymetry of each of the layers of the cornea, not with the Anterion at this point of time.
Martin, would you like to answer this?
Well, we are working on epithelial mapping, which is certainly one aspect of that, which I don't know whether that helps or not, but this is still a little bit way off because, again, because of COVID, our clinical testing sites have been held up. So it's been delayed a little bit, but we're working on that and hopefully not too far away.
Thank you. Rohan, you want to add anything to this?
So a few questions here. There's a question, how does it compare with the UBM STS? So it does not give you an STS. UBM, as we know, is invasive. And for an STS, that's the only technology that's there and it's invasive. So this does not give you an STS. And the white-to-white to our caliper reading, yes. I mean, if you manually do it, it is very much comparable to what we do manually. And yeah, the wavefront analysis of the corneal that Dr. Namrata is going to be covering.
besides the ACD, does it give the AD? Yes, it gives you the AD also. It gives you both the ACD as well as the AD.
Even I think the glaucoma part is going to be covered by Dr. Nikhil in few of the cases. So we can probably take the questions on aqueous pockets in malignant glaucoma after his presentation is done.
Thank you. I think we move on to
Mr. Martin Law.
Mr. Martin, a good friend and a very, very passionate engineer. Always love listening to you, and you know, always, he's always a phone call away. One of the most friendliest technical support for me in the world. Martin, all to you. Over to you.
You're too kind, Professor Shetty. You're too kind. Actually, I think already.
We can't hear you, Martin.
Okay. Sachin?
Martin, we can hear you. We can hear you now.
Okay.
Yeah.
Can you hear me now?
Yes.
Okay. Thank you very much for your kind words, Professor Shetty. I do my best, but I think Dr. Rohan and also Dr. Pooja have already done a very good job explaining what we're doing. So let me share with you my presentation. Here we go. This would be more an overview and a summary what already has been said. So let me be very quick, run through this for you. As Dr. Rohan has already mentioned, we are a multimodal platform optimized for anterior segment. It's 4-in-1. We have cornea, we have cataract, we have metrics, and we have imaging. It's a single workflow efficient solution. So you have swept source OCT technology and ray tracing technology together. You have corneal topography and tomography. You have axial length, IOL calculation, and also anterior segment measurements. Looks like this. The Cornea app, you have all the information that you need for cornea, including total cornea power and total cornea wavefront. You can have multiple views. You can customize according to how you like to look at the information. You can look at differential maps, and you can look at follow-up maps. You can look at the external image of the eye and at the tracking and centration of the cornea, and you can look at the B-scan. With the Cataract app, I don't think I need to describe anymore. It's already done very well by Dr. Rohan, and also the IOL calculation, especially for premium IOL, and the opportunity to manually change your incision position. Metrics has just been very nicely described by Dr. Pooja. We have all the measurements of the anterior segment, and we have 360-degree maps for looking at close-angle glaucoma. Imaging is probably an area where we excel. We like to think we excel. Even you can do peripheral imaging of the sclera. So you can do the whole anterior segment, look at all the structures within the anterior segment very clearly. Just to give you some examples of some images, here we have a DMEC and a DSEC, full thickness graft, bullae, keratoconus, dense cataract already been mentioned, post-LASIK patient, pseudophakic, posterior chamber phakic IOL, intracorneal ring segments, and a bit more complicated case here of penetrating keratoplasty. So you have the latest swept source OCT with ray tracing technology, and we hope that brings you an improved surgical performance. And if that is true, it means that you're going to have better patient outcomes. You're going to have happier doctors, happier patients. Efficiency is straight ahead. it's an improved Pentacam and IOL master all in one. You could also say that it's a Cassia 2 and a Visanti all in one. And 3 in 1 means you have an improved workflow and efficiency. Some of our patients are old or wheelchair bound. It means that you don't have to move them between devices. That means you're going to save time. And if you're saving time, probably you're saving money as well at the same time. You can save space because you only need one device. And if you combine and have only one machine instead of several, maybe you create time to do even more surgeries. Maybe that's possible. Are you sure? Yeah, I'm sure. Oh, really? Yes, I'm sure. We have fast acquisition, and speed improves that patient experience, especially if you're a very busy clinic. It's a one-click operation. Then you start ticking. And this is how it runs. So we align the cornea inside the green box here, and we start acquiring the image. And it's done. Now we're into processing all the data. That's how fast it runs. We do a little bit more processing. In fact, the processing time is faster than the acquisition time. Processing takes even longer. You have your external image. You can see eye tracking position here, center of the cornea. You can see the B scan. You can see the corneal information, your axial length measurement with accuracy of standard deviation. You can see the profile of the A scan, and you also have an automatic quality indicator. And any image that has a high quality is automatically saved so that you don't lose it. So maybe today your data collection, if you have to move between devices, takes 15 to 20 minutes. We think you can reduce that down tomorrow to take maybe 6 to 8 minutes. Maybe you can halve the time it takes you to collect your data. An improved clinic workflow and efficiency means that you save time, you reduce your cost. If you're in private practice, maybe you can make some money. More data makes premium IOLs possible. And of course, you have all the cornea maps, posterior curvature, total cornea, wavefront analysis, anterior cornea, posterior, total cornea power, and total cornea wavefront. You have more data. And so we're faster for getting all the data, and you reduce your tear time. That means you reduce your costs. That's the efficiency that you have with Anterion. It's modular, it's an upgradable platform. You can decide which parts you want. The imaging is central to that. For cataract, you see the entire lens. You see the anterior and posterior capsule. You have accurate lens thickness measurements. And you have swept source OCT for very accurate axial length measurements. We track the eye using these 8 targets on the cornea, and we're tracking the eye to ensure that the patient is always measured along visual axis. So we're always on the cornea vertex. So we should have very good measurement accuracy. You have precise axial length measurements, very low standard deviation here, which has already been pointed out by Dr. Rohan. And even through dense cataracts, because it's swept source OCT, you can get through much better with dense cataracts, even to grade 3. You can see the IOL location, details of your corneal incision, checking distances between IOL and lens, measuring all distances. And maybe if you can see this eye much better, you maybe change the way you think about your surgery. So in this case, with this focal cataract, maybe you want to take a little bit longer than usual to deal with that. And in this case, on slit lamp, it looked as though it was the anterior cortical cataract that we didn't see on the slit lamp. and it wasn't dense. So maybe again, understanding that, we can better plan our surgery. You can get improved results just by looking on these images, perhaps. You can see the limbal and scleral regions as well. For cornea, you have keratoconus possibility to look on with ICR. You can see simultaneously correlate the map to the external picture and also the B-scan. You can look at asymmetry in keratoconus. Here's a DSEC patient. Here's a DMEC patient. You can assess angles very nicely. And you can correlate both together, the map and the anterior segment image. Axial and tangential curvature maps. You decide how you want to look. Elevation maps. Everything is there that maybe you're used to already with previous devices, so nothing different here. Pachymetry maps, total cornea power, and wavefront analysis. You customize the report how you want to see it. So you can have a single view, you can have a multi-view, you can look at both eyes together, or you can do follow-up. Finally, for glaucoma, already been mentioned by Dr. Pooja, you can look at how the anterior angles are. You can quantify all of the measurements of the anterior segment, including the spiral spur. You see very nicely with SWEPS Ortho CT. You can see peripheral iridotomy. Probably you see better on a slit lamp, but you can see it. You can view stents very nicely. We see the scleral spur, we can identify the angle recess. And so we do a radial scan in our glaucoma evaluation, and we look at 360-degree maps. And as mentioned by Dr. Pooja, you can see lens vault very nicely, and you have much better feel for what's going on. Finally, imagine you could have an Anterion and a spectralis together. You have a whole eye evaluation. Thank you very much indeed, and thank you very much for the invitation. I'd like to pass over now to my colleague Adam Hamilton, if I may. He is going to run through a little bit more detail what's on the system. If that fits with the timescale, Shanaz, maybe you can confirm.
Yes. Yes, Martin. Let's invite Adam, please.
There we go. Everyone should be able to see my screen now. So what we're going to do is just do a quick walkthrough of how the software works and how we can look at all this data that we can collect. So we'll start by clicking the thumbnail. Yeah, and for those of you who are familiar with our original Spectralis software platform, you know that for every different modality, you've got to close the screen and open the next one. It's one of the big time-saving features for the clinicians with the Anterion is that you can jump between looking at the cornea module, the cataract module, metrics and imaging live without having to go back and forward and select the next scan. We can set the system up to go straight into a surgeon preference mode. And here's, I know there's some questions floating around about our keratoconus evaluations. We've just added in the PA curvature ratio map in our last software update. All our basic information is here for anterior, posterior, total corneal curvature. We have segment information, we have wavefront information, all of which can be adjusted to a scale that the surgeon chooses. And the nice part for the surgeon is whatever is displayed on the screen when you go into reports is what you can create a report for. So when you're taking information into theatre, it looks exactly the same as what you're used to on the screen, the same layout, so that there's no confusion around metrics or parameters. Looking over at the cataract scans now. Again, as was pointed out, even with without the topography module, and if you've just got the cataract module starting out, you get a lovely pachymetry, a topography map, so that you can see exactly what is happening with the cornea in a lot more detail than you can with other systems. So you can see if it's a bent bow tie astigmatism, if the patient's got a suspect cone, without even having to go in and do a topography. You can see detail of the lens, nucleus versus cortex, so that you can plan the surgeries. You kind of know what you're in for before you get in there. All of these values, you've got the option of manually adjusting, and the same with the peaks. Now, that's one actual benefit that the Anterion has, is you can manually edit those peaks, because if we've got patients with a bit of a membrane over the macula, especially on the IOL master, you can sometimes just get a little bit, the peak can be in the, you can select the wrong peak. And with the IOL master, you can't actually edit that. So for those retinal surgeons that are listening, this is a very handy device. Again, you've got your choice of options here, basic information or premium IOL information. And so the premium IOL information includes aqueous depth, and so that's from the posterior cornea to the lens, and the combination of central corneal thickness and aqueous depth to give what most other machines refer to as the chamber depth. If we go to calculations, and it's just taking it a moment on my laptop. Open it up again. So if we go into our calculations, again, each surgeon can have their own login, their own IOL database assigned, and their own custom template for lens selections. We can pick our list, our lens. When we go into our toric calculator, you'll note one thing that wasn't pointed out is you do have the option of selecting between predicted and measured, and you can switch between the two and again see the change in real time with the Barrett formulas. For all your regular formulas, you've got the option of selecting between total cornea and anterior cornea curvatures. So you've got full control over what data you're using for the calculations. Again, what you see on the screen is what you get on the reports. So you get all the alignment information, everything like that. If we go in and have a look through metrics, again, we can turn on all our overlays, select what we'd like. And if we have a look at an imaging case, or as I like to call it, free play mode, because if you can see it on the front of the eye, you can image it. You can actually see this patient's had a glaucoma shunt put in. So you can actually see how that's sitting in there. The software is very easy to use, very user-friendly. You've got options in the software, in the newer versions of the software that the Anterion ships with, for creating your own custom lists for presentations. So instead of having to sort through a big list of patients, you can just drag and drop them into a group or for research purposes. And it will automatically just select those patients that are involved in that particular study. And we now have, with the new Anterion software, the ability to batch export different parameters. So if you were looking to do a review of cataract axial length measurements against your existing machine, you can export all the data for all the patients very, very quickly and easily. So hopefully that's given everyone a nice brief overview of how simple the software is to move around and navigate, and show that there's a lot of customization features available for surgeons, so that every surgeon in the practice can have their own variation that suits them. And I'll throw back to Shanez now.
Thank you very much, Adam, for a good presentation. May I request Dr. Namrata Bhuta to give us a talk on, she's going to talk to us about her frank evaluation of the Anterion for topography. So Dr. Namrata, please come in.
Yes, ma'am. Thank you for your introduction. Is my screen visible?
Yes, it is.
So I'm going to be talking about how good is the topography on Anterion today. So up until a few years ago, when a cataract patient came to us, just doing the biometry was enough to achieve the target vision of 6.6. But this is no longer the case now. The patient not only demands a good quantity of vision, but he also wants a good quality of vision. So just doing the biometry won't be enough. So we have to include the topographer and the aberrometer in our routine cataract workup. So this is where Anterion comes into play. It acts as a one-stop shop solution for us, giving us everything in one machine. That is your topography, your aberrometry, your biometry, as well as your ASOCT. Now, as we've already discussed, it has got 4 main apps. I'm going to be talking about mainly the Cornea app today. So to give you an overview, the Cornea app gives you these different views. There's a single view, there's a follow-up view, there's the ODOS comparison and a multi-view. I'll be talking about each of these as we go ahead. Beginning with the single view. Now, this is where you get a single map. Either it can be a map of your axial curvature or your tangential curvature for both the anterior and the posterior surface. You also have the elevation map for your best fit sphere, elevation maps with your best fit sphere, and your another very important feature is it also gives you an elevation map with a best fit toric ellipsoid. You also have the routine pachymetry maps and the total corneal power map. Now I'll be talking a little bit more about total corneal power as I go ahead. So coming first to the basics that it gives. So yeah, so it gives you here the anterior. So this is the basic map for the corneal topography. Now it gives you here the simulated K. So for both the anterior as well as the posterior surface of the cornea. Now the anterior, basically the SIM-K is the average of the keratometry values and the steep and the flat meridians, which are 90 degrees apart, and it's measured only in the central 3 mm zone. It also gives you the total corneal power. Now, what exactly is the total corneal power? The total corneal power is a ray tracing calculated power from which takes into account both the anterior and the posterior curvature of the cornea. This is not the case with your SIM-K, which only takes into consideration your anterior corneal surface. Now, this total corneal power, especially, you cannot use it in all formulas, but you can use it in your Holiday 2 formula. Apart from that, it also gives you your corneal pachymetry and your pupil diameter. It also gives you the X and Y coordinates to calculate your angle kappa. Now, coming to the next part, which is the segment parts. Now, it divides the entire, this map divides the entire cornea into different either rings or zones. Now, why is this important? This is mainly important. If you see, this is how it divides into zones of 2 mm, 4 mm, 6 mm, and 8 mm. Now, the zones are mainly important, especially in cases of irregular corneas, where you want to know how regular is your cornea. Looking at, so it gives you the astigmatism in various zones, and looking at the astigmatism, you'll be able to identify whether this is a fairly regular cornea where you can actually go ahead and plan your toric IOLs or not. So coming next to the wavefront map. So in the wavefront map, there are two maps that it gives. It's the anterior corneal wavefront map and the total corneal wavefront map. Now, the total corneal wavefront map also gives you the total of the lower order aberrations as well as the higher order aberrations, looking at which you can go ahead and plan your multifocal IOL patients. We'll be talking about that ahead. Another thing that it gives you, especially very important in patients of ectasia, gives you the baseline and the follow-up map comparison, along with the follow-up and the baseline difference map that you find in other topographers like the Pentacam also. Coming next to the multi-view. Now the multi-view gives you multiple maps at the same time. You can have the anterior axial, posterior axial maps. There are customized templates also available for keratoconus, for posterior keratoconus for post-refractive surgery patients. And according to the customized templates, the surgeon will be able to see the maps that he desires to see in the multi-view. So how can Anterion actually help a cataract surgeon? So it helps in multifocal IOL planning. Now, when a surgeon is planning for the multifocal IOL, what he really needs to see is the pupil diameter, which is given by your basics map. If the pupil diameter is less than 4.5 mm, the patient you can go ahead and think of planning a multifocal IOL. Another thing you need to see is whether the topography is, it's a normal topography with astigmatism being less than 0.75 diopters. You also need to see, the most important thing is see the aberrations, especially the total corneal wavefront parameters, which will give you the higher order aberrations. These higher order aberrations have to be less than 0.5. Only then you should go ahead and plan a multifocal IOL in these patients. If it is more, these patients are more prone to have higher amount of glare and halos after the surgery. Coming next to aspheric IOL planning. Now, your wavefront map also gives you the spherical aberration. Now, the spherical aberration, depending upon the amount of total spherical aberration in the cornea, you can plan the type of IOL that you want to implant. If you are having an aberration in the range of, say, more than 0.16 to 0.33, you can go ahead and implant a negative SA IOL, either an Alcon IQ, or if it is more than 0.33, you go and implant an AMO Technis, which actually has a negative SA of minus 0.45. Okay, so coming next to the toric IOL planning. Now, in the toric IOL planning, again, you can take in the values from the anterior axial curvature, that is your SIM-K values, and put it in the toric IOL calculator, and then calculate the toric IOL power. You can also use the inbuilt toric IOL calculator, which is there in the Anterion itself, which already Rohan has talked about. Another thing is about toric IOL planning in irregular corneas, especially in ectasias and post-refractive surgery. You can use the segment zone map, see the various zones and the astigmatism in these zones, as well as the K values, which will tell you what usually we take the 4 mm zone into consideration, as most mesopic pupil diameters are about 4 to 4.5 mm, and this is what has proved in various studies to give you an accurate toric IOL power in these irregular corneas. So coming to the end of my talk, I think the Anterion has a very, very robust cornea app, which helps the cataract surgeons in various ways, as I've already talked about. Hello, Shehnaz, are you there?
Yes, I am. Thank you very much, Dr. Namrata. Dr. Nikhil, would you like to come in, please? Dr. Nikhil will be presenting some cases that he has done and share with us his experience.
Is my screen visible?
Yes, it is.
And am I audible clearly?
Absolutely.
Okay. So at the onset, I would like to thank Toshbro, Dr. Rohit Shetty sir, and Shehnaz ma'am for giving me this opportunity to talk on this platform today. So I'm basically going to be sharing with you all a few cases that we've come across in our practice, where we've used the Anterion for various different purposes. So first case today I'm going to be discussing is the mature cataract. Many people have already been asking that what does the Anterion do? Can it penetrate through a mature cataract or not? So here we see a completely dense mature cataract, and we see the other biometers here. If you see, we had to do a manual entry because both the IOL master and the lens star could not penetrate the mature cataract and could not give us the axial length. Here we see an image of the Anterion, and here we can see the same mature cataract. And what do we see here is that the axial length was measured on the Anterion successfully. Using this, we could do the IOL power calculation and find out the IOL power for this lens. Here we also see in this case that in the calculation of a mature cataract, sometimes when you have a very dense cataract, the high resolution OCT is so good that we can clearly differentiate between the different layers of the lens. Like here we could see the cortex and the nucleus, which is well separated from each other. Coming next to the case of a posterior polar cataract. So here we see a sequence of images of a dense posterior polar cataract. And we see here in the next case example. So what it does is it takes different sections of the eye. And what we see here in the third image is that there is an opening in the posterior pole, okay? And we had to be very careful during surgery. But even though we were careful during surgery, just during a hydrodissection, there's a posterior polar cataract seen. During a hydrodissection itself, coming next to a toric IOL planning, I think some part of it has already been covered by Dr. Namrata. So basically what we usually do in our regular practice is we use the EKR map from the pentacam to differentiate whether the cornea is regularly irregular or irregularly irregular. Now 2, 3, 4 millimeter zones, and therefore we can classify whether the cornea is regular or not. So here in the Anterion in the Cornea app, we can also find out using the different rings, the 0 to 2 millimeter, 2 to 4, 4 to 6 millimeter rings, whether the core are toric calculations too. And what we can do is we can either use the anterior corneal, that's the SIMK values, or we can even use the total corneal power. Though we have to keep in mind that if you're using the total corneal power, we should not be using it in the regular online calculators for the toric IOLs, but we should be using it only in the Holidays formula. If wanted, we can also do a toric calculation on the Oculix software of the Anterion itself. I think Dr. Rohan has already covered this part, where we can directly select the IOLs from, we can have it has its own planning station where we can do the calculation. Now coming next to a multifocal IOL. So as already discussed, in multifocal IOL, we need to make sure that the cornea is regular. It has a good corneal topography. Second point we need to take into consideration is the wavefront. As we see here, the patient has minimal lower order and higher order aberrations. And also the next thing that we take into consideration is the pupil diameter. Obviously, if the pupil is too large, then in those cases, the patients do suffer from negative dysphotopsia. Also, another poke is the angle alpha and angle kappa. And I think people have asked questions on the same too. So basically angle alpha is something that we cannot calculate using the Anterion, but angle kappa, as you see here, we have the X and the Y coordinates. So using the X and the Y coordinates, the angle kappa can be calculated. And hence we all know that if the angles are usually large, if you have a large angle kappa, then we should not go ahead with the multifocal IOL implantation. Now coming to the next segment is the post-refractive surgery planning. Now, usually patients who have undergone prior LASIK, we use the online ASCRS calculator for the myopic or the hyperopic LASIKs. And what do we need here basically is we need the ISIS or the effective RP values, which we get here from the Pentacam EKR map. And we also again need the ring values of the 0, 1, 2, 3, 4 millimeter zones. So as I already discussed earlier also, here we have the different zones. As you can see, the 2, 4, 6, 8 millimeter zones. We can enter these values in the online ASCRS calculator. And this can be, therefore, having an Anterion can be good enough while even we are planning a post-refractive surgery patients now undergoing cataract. Another good feature on the Anterion is that if you do not want to calculate using the online calculator, it itself has the Haigis L formula, which is specifically for the post-refractive surgery patients. As you see here, this is a post-refractive patient that we have, and we use the Haigis L formula. And we compared these with the ASCRS online calculator, and we were pretty close by. It was just 0.5 diopters off. Coming next to an interesting case, which we noticed, there are a few interesting cases that I'm going to be showing you all. So here we see a case of an IOL glistening. As we see, this is a pseudophakic patient, and both the anterior and the posterior part of the IOL here shows glistening. So basically, as again asked in some of the questions, the machine does not have a lenticular. It does not show you the lenticular aberrations. It does show you the corneal, but lenticular aberrations is not a feature of this. Next, coming to keratoconus or the corneal ectasia, as seen here, we have the wavefront parameters out here. So as seen, there is a large amount of coma, large amount of trefoil, which is expected in these patients. And what we also see here is that the vertex, we can see the thinnest point and the vertex, and we can see how far apart they are. We can see areas of steepening. So as we see here, even in this, we could do a calculation in an irregular cornea, and we can do an IOL power calculation for the same. Now coming to ICL, it's already been dealt with well with Dr. Pooja, and as she was telling you here, what we can do in ICL planning is we can not only do a measurement of the central vault, but also of the vault in the periphery also. So sometimes we do see that if maybe an ICL haptic is not tucked in properly or something, we may see a difference in the vault in the peripheries also, which is an important thing because we need to re-intervene in these cases. So another important feature here, if you see, is there are various different formulas for doing an ICL planning nowadays. Obviously, the ICL that is from the Star Surgical Group and all ask for the white to white. But then there are other calculators which ask for your sulcus to sulcus. There are some calculators now for the angle to angle. So the Anterion gives you not only the ACA distance, the angle to angle, it gives you the spur to spur distance, and it also gives you the white to white. So once you mark out the scleral spurs, which can be easily done because of the high resolution OCT, we can then come to know these values. Now, another important feature is something called a lens vault. The lens vault is the distance between a line drawn from the two ends of the roots of the iris up to the anterior capsule of the lens. So the yellow line you people see here is what the lens vault is actually. So here, if we see in this case, it is a negative lens vault. It is minus 0.85. In such cases, these patients are more prone to an angle closure because you see the lens is completely approximated with the iris. Now coming to ICL vaulting. So as discussed already, low ICL vaults are known to cause cataract. This is one patient who came to us. We've done serial OCTs for her, and we've seen the values remain round about 250 itself. The lowest value we got over the 3-month period was 230. So we did not, luckily till now, we've been doing her, we've regularly been doing her checkup. She has not developed any cataract, and we do intend to follow her up in the future too. Further coming to large vaults, this is one of the patients who was referred to us from outside. The patient, if you see here, has a vault of almost 1100 microns. Again, we decided to follow up the patient. We did serial scans and we saw the vault was constantly increasing. The final vault we had was almost went up to 1200 microns. You can see the angles here, how narrow they've become in this case. So we decided to explant the ICL and do a re-implantation in this case. Here again, these are different images that we have seen in this thing. Here we see the high resolution OCT in a patient who had undergone a DSEC at our place. If you see here, clearly see the graft host junction here, you can see how well opposed it is. There is no fluid cavities or anything in between. So the high resolution OCT is so good, you can come to know the exact depth at which the graft host junction is also attached. Coming next of the image, this is a patient who had a single intact ring implanted for keratoconus. You can see the exact intact ring. You can use the measurement features and you can actually calculate the depth at which the intact ring is actually placed. Coming to a case for conjunctival nevis, as the question was asked earlier also, this not only images the cornea, but you could, if it go up to the conjunctiva and the sclera lying below, here you could clearly see a conjunctival nevis, and you could see it's how well it's been imaged here by the Anterion. This is another case here of the DMEC, this is just a quick post-op. I think this is a third day post-op, or first day post-op case here. We could also see how well it's picked up a soft contact lens which is being placed over the eye. And this is a patient who was using a rigid contact lens for a keratoconic patient who was using rigid contact lens. Again, we can see how well it's fitted over the cornea. Again, another picture here of the iris cyst, which we picked up, which we've also shown out here. So finally, as Dr. Rohit Shetty said, in this era of COVID, where time is so precious, we don't want patients roaming around the whole hospital, going to different rooms. We need a one-stop solution. So the Anterion gives us just that. It gives us a built-in biometry. It has the anterior segment OCT. It has the topographers, and it also has the wavefront aberrometry. So in this era of COVID, where we need to save time and we need to prevent patients from moving from room to room, I think the Anterion is the perfect one-stop solution, which is going to give us all the going to give us all the things that we need for an anterior segment surgeon in today's time.
Thank you, Dr. Nikhil. Thank you very much for this presentation. Are there any questions for which you would like to answer? There are some questions I see for the panelists. So before we wind up, I believe there are questions that we can write back to you, doctors. because they're very specific and they're very elaborate questions. But to answer just a couple of them, from the company side, I believe there are some questions and queries on the pricing of the equipment. I would like to tell you that this is a system that is modular. You can build in the imaging app, of course, is a standard thing in the system, but you can add on the apps depending on what your needs are. And obviously the pricing also varies accordingly. So I would be connecting with you individually to answer those queries of yours. And if you need to, please connect with me. My email address is stamane, STAMHANE @toshbromedicals.com. You must have got the invite from me. So please connect with me. If there is anything specific you'd like to ask the panelists, they are also available to you. Please connect with me and I will forward your queries to them. And with this, I would like to wind up the meeting. Thank you very much, Dr. Shetty, Dr. Rohan, Dr. Nikhil, Dr. Amrita, Dr. Pooja, thank you very much for being with us. Adam, Martin, I thank you again. Especially Adam, because it's nearly midnight for him in Australia. He's in Australia, so it's like midnight for him. So thank you, Adam. And thank you, doctors, for spending so much time with us. Stay safe and good night. With this, I close the meeting. Thank you very much.
Thank you.
Thank you.